Good morning, everyone. Thanks a lot for joining us for today's seminar. I am quite excited to introduce Professor Becky Smith. She's an associate professor in the College of Veterinary Medicine here at the University of Illinois. And just to give you a background on the work that Professor Smith has been conducting at the University of Illinois, her expertise is as an epidemiologist. And what she does is she tries to abstract knowledge from messy and incomplete data using mathematical and statistical modeling. And her home institute is the College of Veterinary Medicine, and she has affiliations at the CAII Institute for Genomic Biology, also with NCSA, and with our Center for AI Innovation, and the Carl Illinois College of Medicine. And she works on a variety of topics, including zoonotic tuberculosis, vector-borne diseases, menopause, and lately on COVID-19. So I'm really intrigued about the presentation she's going to have for us today. So welcome to our AI seminar series, Professor Smith, and we look forward to your presentation.
Thank you very much for that nice introduction. I will say that I'm mostly going to be talking about vector-borne disease today. I would love to tell you some great research on COVID-19, but unfortunately, health takes priority over research. And so my operational work on public health and COVID-19 means I don't have time to do research on COVID-19, but I will apply some of what I'm talking about to thinking about COVID-19. And one of the things I'm really passionate about right now is data heterogeneity and how that impacts our precision and accuracy for disease surveillance. So I'm going to dive into West Nile virus. And this is work that's mostly been done in coordination with the Midwest Center of Excellence in Vector-Borne Disease, which is a CDC-funded center. Now, West Nile virus is transmitted by primarily these Culex pipiens mosquitoes. It can cause severe illness in people, but just like COVID-19, the majority of people have very nonspecific cold fever-like symptoms, if any, and then a very small number of people have severe illness and it can cause death. Now, Northeast Illinois has been a hotspot for West Nile virus since 2002, and the Chicago area is usually one of the highest case number counties in any given year. Now, we do West Nile virus surveillance by looking at the mosquitoes. And we use this term called MIR, which is calculated as the number of positive mosquito pools, because you never test a single mosquito. You group a bunch of mosquitoes together and test the pool of mosquitoes that's all been mashed up. And that the number of positive mosquito pools is divided by the number of mosquitoes in all pools. So MIR is it stands for minimum infection rate. So it kind of compares to test positivity, if you've heard that term, but it's saying, okay, but we don't know how many infected mosquitoes were in this pool, so we're just going to assume it was one. So it's the minimum infection rate. Now, we've got a problem with sampling bias in West Nile virus, and this work that I'm presenting was done by Sulagna Chakraborty, who is a PhD student in our program for ecology, evolution, and conservation biology. And she was a summer fellow with the Midwest Center of Excellence. And she did some work looking at how the MIR might be biased based on sampling heterogeneity. So this is a map of Illinois. Hopefully you recognize the state of Illinois. And you might see the different colors for each county. That represents the average MIR over 3 weeks of 2016. Now, 2016 was an extremely bad year for West Nile virus. And these 3 weeks, weeks 35 to 38, are mid West Nile virus season. So this is bad year at what should be a bad time. So this shows kind of what the maximum risk would be. And the darker the color, the higher the MIR. So you can see it's fairly heterogeneous over the state. We've got these areas up in the Chicago area that are pretty high levels, and we've got these areas down in southern and central Illinois that are a lot lower. Well, that seems like, okay, this is heterogeneous data, fine. And then we overlay on this where the traps are. So these are where the mosquitoes are collected. Now, each trap is a single collection point. The size of that bubble is the number of pools that we collected from that single trap. And if you see the light green ones, that just means we don't know exactly where in the county the trap was, so it's just been placed at random in the county. So you can see that not only is the value heterogeneous, but where we are actually collecting the data for that value is extremely heterogeneous. You can see up here in the Chicago area where it's at very high risk, we're almost saturated with traps. We've got a lot of traps up there. Down here, okay, there's no West Nile virus detected in this county. There's a lot of traps, they're spread out over the county. I'm okay with calling that a 0. But what about this county where there's 3 traps, a few pools, but they're all over in one corner of the county? Is that a real 0? How about this county to the north of it that has 0 traps over the biggest 3 weeks in a very bad year? We don't really know what the value is in that county. There's an entire 7 county section here with 0 traps. Those zeros I'm not too comfortable with. On the other end, the high end, okay, so up here we've got a very high level, but we've got, again, a lot of traps spread out over the county and a lot of pools going in. Now, how about this county where we've got a pretty high MIR, but all of the traps are pretty much over on the eastern edge, which is where the people are? How do I feel about that entire county being labeled as a high MIR? Maybe not so good. And how about these counties over here that maybe have 1 or 2 traps, but have a very high MIR? This one in particular up here, it had 1 pool submitted in this 3-week period, and that pool happened to have 7 mosquitoes. So the positivity was pretty high because 1 infected pool with 7 mosquitoes looks like, oh my gosh, 1 in 7 mosquitoes is infected. But that's not because 1 in 7 mosquitoes is infected. It's because you only tested 7 mosquitoes. Now, the problem here is that these counties have limited resources. So not all can do the testing that's necessary. Not all can do what the Chicago area does. And not all necessarily need to do the same testing, because Culex pipiens and Culex restruans and Culex salmonarius, which are the 3 mosquitoes that mostly transmit West Nile virus in Illinois, they're not everywhere and they're not as big a problem everywhere. But we asked, well, what kind of error could we get in the MIR from sampling less? So we took these 2 counties up here, Cook and DuPage counties, which are highly sampled. And we said, what would happen if we took away some of those samples at random? So for all weeks sampled from 2007 to 2016, Sulagna at random sequentially just selected a certain percentage of the traps to calculate the MIR. And she did this over from 10% to 90% of the traps available. This is a value of information approach. It comes from economics. And then she calculated the MIR in the sample and calculated the relative error, which is the MIR in the sample minus the observed MIR, and then divided by the observed MIR, because we want to control for the actual observed MIR. And I say observed because it's not necessarily the true MIR, it's just the one that we observed with the full data. And then she calculated the trap density, so how many traps per square mile. And you can see the results in this graph. So trap density is on the x-axis, and you can see that as trap density increases, the relative error decreases, relative error being on the y-axis. But what you also see, the color is associated with the observed MIR with all of the data. And what you'll see is as the color gets darker, you tend to get a little bit more spread on that error. So as you have a smaller signal, smaller MIR, we get more relative error. And so we did an analysis, we did a log normal regression for relative absolute error. And what we found was that a higher MIR results in a lower relative error. If you got a bigger signal, it's easier to find. A higher trap density also results in a higher or a lower overall error. And they are actually significantly synergistic, meaning that they combine. So if you have a low density and a low actual MIR, you will have a higher error than if you only have one of those values being low. So what does that mean? So here's Cook County over 2 years. We see the observed MIR. The red bar is what the error around that might be if we only used 10% of the traps in Cook County. And you can see that it doesn't change our value very much because Cook County, one, it tends to have a higher MIR, and two, it's very well sampled. So we have a really good sense of what the MIR is. Now here is a county that doesn't sample as much, and you can see the blue bar is what we estimate to be the error using 100% of their traps. So they have more error using 100% of their traps than Cook County would have using 10% of their traps. So this matters as far as how we're communicating to the public and making decisions about mosquito control, because a lot of decisions made about mosquito control and when we tell the public that there is risk is based on what we see the MIR being, especially when that MIR first starts to rise at the beginning of the year. And there is a good chance that we would miss that rise and we'd be a little slow in sending out the message because we just don't sample enough. And this is counterintuitive. A lot of the mosquito control districts, they put out more traps in the middle of the summer when West Nile virus activity is higher because they want to have a better estimate of what's going on. But actually what we found was that it's more important to have more traps at the early stages so you can find the infection faster and have a better idea of when it's starting to rise, which does have some parallels with COVID-19. So that's one heterogeneity and surveillance effort. Let's talk about another. And this is work that was led by Chris Stone, who is the director of the Medical Entomology Lab at the Illinois Natural History Survey. And he did a lot of really wonderful genetics work that I won't talk about. But what we did was looked at the observations of Aedes albopictus. That's this beautiful mosquito right there, beautiful, and I hate it because it hurts when it bites you. If you live in Urbana, you know this mosquito. We have plenty in Urbana. So we took all known observations of Aedes albopictus in the state of Illinois. This is an invasive species, and we want to know, is it here and is it living or is it just being reintroduced all the time? So we looked at possibilities of tire imports, which is one way that Aedes albopictus tends to be introduced to an area. We also looked at climate, road networks. Chris's lab looked at population genetics, and we looked at surveillance efforts. So Aedes albopictus and its cousin Aedes aegypti. Why do we care about these? By the way, they can carry yellow fever, they can carry Zika, chikungunya, they can carry all sorts of viruses. In Illinois, they do not, but they could if the virus was introduced. So we care about where they are because they could spread disease. And generally we say that we have these isotherms. This is the January average temperature. If it's below 10 degrees Celsius, or in the Southern Hemisphere, if the July average temperature is below 10 degrees Celsius, we say it's probably not going to overwinter, meaning if it gets introduced one summer, it's all going to die out and it'll have to be reintroduced the next summer. So we said, okay, what's the probability of albopictus being present given this overwintering probability? So if it was there in the previous year, and we know what the winter temperature is, we have some idea of overwintering. We also added into this that there is an urban heat island effect. So the Chicago area, and I believe Peoria and Springfield also had the possibility of having an overwintering due to an urban heat island. We also looked at if it was present in neighboring counties, could it diffuse from the neighbors? Excuse me for 1 second. So we wanted to calculate the probability of Albopictus being present in a given county. But the thing is, we don't have data on whether or not it's present. We have data on whether or not it has been observed. And we know from what I talked about earlier with the West Nile virus, it's the same system that actually looks for the Albopictus. So we know that the detection effort is not the same in every county. So we took that into account as well, and we built a hierarchical Bayesian model to calculate that. So here, a little bit more detail on the isotherms. We know that Southern Illinois should be below this 0 degrees isotherm, so it should be able to overwinter in Southern Illinois. Central Illinois, maybe, and Northern Illinois, it really shouldn't be able to overwinter, assuming it's not adapting, which is a story for another day. So we took all of these observations over 5-year periods. Here's the cumulative number of observations in each of the counties in Illinois. And we fit this hierarchical Bayesian model. And so things we can see. So looking at overwintering, as the overwintering index increases, meaning that there's warmer Januaries or an urban heat island, we see a higher probability that it could overwinter, but it's still not very high. If we look at the probability of diffusion over 5-year periods, it increases over time, but it's still not very high. And if we look at how likely are we to detect the mosquito, given that we are doing a different value of effort, if we're looking, we know that we're likely to find it. Not guaranteed, but we're likely to find it. But if we aren't looking, there's a very good probability that we wouldn't find it, which obviously, if you're not looking, you won't find it. So we calculated this posterior probability of the mosquito being present. And you can see that it tracks fairly well with our observations, filling in some of these gaps here where we have zeros and we think, well, given what's going on in the counties around them, it's probably there. But you'll see that there are these patches of dark, we don't think it's there. Well, if you overlay where the testing is, all of this dark right here, there's no mosquito traps. Again, this dark right here, there's hardly any mosquito trapping going on. So how confident am I in this posterior probability of presence? I think we need a lot more information from mosquito trapping before we can say confidently it's not there. I think we're pretty sure that where we say it's likely to be there, it's there, but absence of evidence is not evidence of absence. So let's talk about where those traps are. So where did we put our mosquito traps? And this is work done by Serena Schatz, who was working again as a summer fellow with the Midwest Center of Excellence. And she's continuing on with this work in my lab as an hourly student, or not a student, she's an hourly. So she's looking at all of the traps. This is DuPage County. So to orient you, Chicago is right over here. So it's right up there next to Chicago. Fairly high population density in the eastern edge. In the western edge, it's more parks and landscaping. And she's looking at these individual mosquito traps and asking, how well do they predict what goes on in the county as a whole? So we're going to ask, if it's a very yellow colored trap, that means that it's a much higher MIR than the overall county. And if it's a very purple trap, it means it's a much lower MIR than the overall county. So you've got traps like this here that are really over predicting MIR compared to the overall county. Is that because that location is a very high MIR place? Or is it because that trap only gets put out during the very high activity season? And then also up here, we see a lot of very low levels. Is that because this is a low activity, low risk area, and the people who do mosquito control can do a little less control up there and spend their limited resources down here with the high values? Or is that because of some other factor? So we're looking at, here is a leave one out analysis where she one by one takes the traps out of the data and finds out how much they impact the overall county MIR. And one thing you'll see is that the mean value doesn't shift it very much. You get a really wide variability. So these traps, none of them are consistently high or consistently low, but some of them tend to be higher producing and some of them tend to be lower producing. And we had a summer student this last summer, Patrick Ringwald, who was working for his MPH practicum on trying to understand what is it about those traps that makes them higher producing or lower producing. So far, we have no results. We don't have anything popping out. So this is a continuing area of research. But the question is where the traps are might be as important as how many traps you have. And then thinking about all of those heterogeneities, switching to ticks. Ticks in the state of Illinois, we are at the leading edge of invasion of multiple tick species. Hooray for us. So we're looking at what data do we actually have on where the ticks are, because then we can tell people better where they need to protect themselves, and we can prepare the medical community for potential tick-borne diseases. So a group associated with my lab, but not including me, did a historical analysis where they went through all of the research studies, all of the outbreak investigations, any surveillance efforts, any data we could find, and mapped where we know ticks to be established. And established means that there's 2 life stages or at least 6 of any life stage in a given year. So it's not just a tick fell off a bird and we found it, but it's probably living here and reproducing. Or reported, which means we haven't met the established criteria, but we found it there. And no report just means we don't know. So they've collected all of that information. And then Leanne Lyons, Dr. Leanne Lyons, who is a PhD student in my lab, she has been putting together this iTick surveillance program, which is a community-based science project. So we ask people to send us ticks. Because of this summer, we didn't want them actually sending us ticks with the mail and working through our hubs that we were working with. So we are actually partnering with the Tick app where people can take pictures of the ticks. We'll identify it for them, and we have the pictures and where they took the picture. So we got a lot of information. From the first year of iTick, we learned a lot about where ticks were just because we couldn't be there. We also do active surveillance. We go out, we look for ticks, but we can't go everywhere all the time. So with people sending us ticks, we have added all of this more information, all of these hash marks. This is new information just from 1 year of the iTick program on where ticks are in the state. So this is adding a whole bunch of information on where the ticks are. And in the future, we can test those ticks for pathogens. We can start working with doctors and with veterinarians to understand tick-borne disease. This gives us a lot more information. But before that, you can imagine how little we knew about tick-borne disease in the state simply because nobody had looked, because it's a lot of work. So why are people using the approaches they're using that we have this heterogeneous data? Well, this is from a survey that Serena Schatz did as part of her fellowship, that she asked a whole bunch of mosquito surveillance groups why they made their decisions. And the number one thing that kept popping up was budget. Did they have staff? And did they have equipment? So that's really the limiting factor in how we know about this, all of these diseases. Another survey, which was led by the Northeast Center of Excellence for Vector-Borne Disease, asked people who were involved in tick surveillance. What were their major barriers to doing tick surveillance? And again, number one, funding constraints, lack of trained personnel, and competing priorities. So the thing that keeps people from doing the best practices, from doing this homogeneous surveillance, giving us really great data, is that they don't have the money for it. So how does all of this apply to COVID-19? Well, COVID-19 is what we call an iceberg disease, meaning these deaths in severe cases we can find in hospitals, we can look at excess mortality, all of that we can observe pretty easily. But as you move down the pyramid to less and less symptoms or less and less exact symptoms, it's harder and harder to find them, and you need active surveillance. Now on the UIUC campus, we're doing active surveillance, so we're seeing all of this. But in most cases, they're not. So we end up with cases being the observed cases, not the actual infections. So what does that mean for us? Well, ask yourself, where are the testing locations? And here is a map of testing locations in the state of Illinois. And if you look at that map, you can say, all right, if I live in the Chicago area, there's plenty of places to get a test. If I live in West Central Illinois, I might have to drive a little while. Also, think about if the testing locations are primarily drive up, as they are in Champaign if you are not on this campus, and you don't have a car, can you get tested? Think about who is allowed a test. Do you have to have symptoms to have a test? Do you have to have been exposed? Are you allowed to test if you have been exposed? There were some very silly CDC guidelines at one point saying that, well, if you've been exposed, don't bother testing, just stay home. Do you need insurance? So are people without insurance not being able to test because they can't afford to? You should also ask what test is used. So Illinois is one of the states in which antigen testing is used, but it's not reported by the state in their testing data. That's because antigen tests and PCR tests are not perfectly comparable, but we don't even know yet how comparable they are. We're working on that. Also to think about is where the testing sites are located by some of the major disparities. So 538 over the summer did this great analysis where they looked at the demand at COVID-19 testing sites, so how long you have to wait in line basically. And what they found was there is a higher demand in areas that are majority Black or majority Hispanic in most of the country, meaning that there's greater test availability in white neighborhoods than in majority minority neighborhoods, which tells you a lot about where the heterogeneity in the COVID-19 testing data is going to come from. And then you think about what we call ascertainment bias. So one of my favorite tools for COVID-19 risk is this Georgia Tech COVID-19 risk map, which they tell you in this case, what's the probability that a party of 50 people has at least one infected person in it? Very easy to understand thing for somebody. If I'm going to ask, do I want to go to that wedding with 50 people? I can look at this map and say, no, I do not, because there is a 75 to 99% probability that somebody at that wedding is infected. But one of the things they had to do was say, well, we know that the observed cases, which this is based on, is not actually the total number of cases because there's a lot of unobserved cases in everywhere basically but the UIUC campus and a few other campuses. So they have two different levels of ascertainment bias. They either say, well, 1 in 5 cases is detected. So for every case they find, there's 4 more that they don't find. Or 1 in 10 cases it is detected. And you see from the left-hand graph to the right-hand graph, that makes a big difference in the probability that you're going to have an infected person at that party of 50 people, which this is a good sense of some of the uncertainty, but let's add in this map of where testing locations are in Illinois again. And you say, okay, so in this West Central Illinois, we've got some pretty high risk based on ascertainment bias. We've also got almost no testing sites. So is 1 in 10 even appropriate? Whereas up in the Chicago area, you don't see much shift, and you've got a lot of testing locations. Now, I mean, this is not tests per capita, so there's a lot more people up there. But it's something to think about when you're thinking about the uncertainty in these values. Think about where the testing sites are located and what that means about which ascertainment bias you might want to use. Now, another group did a preprint that came out in September that I think was really interesting, that looked at excess mortality as a factor of different values. So they estimated excess mortality, and then they looked at the residuals of that model based on various factors. So for instance, they found that excess mortality was higher when there were a higher percentage of non-Hispanic Black individuals, and lower when there was a higher percentage of non-Hispanic white individuals in a particular area. Likewise, they overestimated excess mortality in areas with high home ownership. They underestimated excess mortality in areas with high levels of residential segregation. So this gave them a sense of what could be affecting their estimates and the data that goes into that. So the big takeaways I want you to get out of this is that we're trying to make COVID-19 decisions based on data. And COVID-19 data depends on surveillance effort. And that surveillance effort is heterogeneous. We know that. We know that there are more testing sites in white upper class neighborhoods. We know that there's less availability to poor, to under serviced hospitals. We know that rural areas are less supported as far as testing. Remember, this came from September. A lot of the cases now are coming in rural areas, so I'm sure that this graph looking at rural is going to change a lot. So the important thing to think about is that our COVID-19 decisions, if they're based solely on the pure numbers, the pure data, may be worsening disparities. We need to actually look at not just the data, but where the data are coming from and how they were collected, so that we can understand whether to interpret them perfectly at face value, which you should never do with data, especially health data, or if we need to adjust for understanding where some of the uncertainties could be built into the process. Now, I need to thank a lot of the people who have helped out. The funding for all of the mosquito and tick work that comes from the CDC, the DoD, NSF, and NIH. We get a lot of funding from a lot of different places, and I'm very grateful for that. I have some amazing collaborators on that work from the Natural History Survey, from the Department of Statistics, and University of Maryland. And I have to thank Marilyn O'Hara Ruiz, who started this program, and I've just tried to keep it going after we lost her 2 years ago. And she did an amazing job putting this program together, and it's been really great to work with. I also have to thank all of my lab members. We have a big team that's worked on it over many years. Have some people who work on things other than mosquitoes and ticks. So we've got a lot of work going on. And if you want to find out more about iTick or about our West Nile virus prediction models, those are available there. But at this point, I'll stop and I'll take questions.
Thank you very much, Becky. Let's give a hand to the speaker. It was a very fascinating talk. All right, so anyone, please feel free to unmute and ask the question that you have had in your mind over the last few minutes. Please go ahead. Okay, let me start. I was very surprised. I would even say shocked to see the first few maps that you showed about the number of cases that you identify and the actual means that you're using to find them, right? So can we even say that the results that we present to people interested in this type of diseases are to some extent misleading? Because you get a false sense of security, right? You say, oh, there is no problem here, but actually you don't even know whether there is a problem that you should be concerned about.
Absolutely. With health data, there will always be potential issues as far as where are the data coming from. So you can never just look at the pure data. You have to see how was it collected. One of the things that's important with West Nile virus, I was talking about data on mosquito infection, not human cases. We also look at the human case data, but we have to look at separately all cases versus the neuroinvasive cases. Neuroinvasive cases are the cases that end up in the hospital and could lead to death. Those are a lot easier to identify. You're not going to miss many of those because somebody having a severe neurologic disease is going to get some medical attention. The non-neuroinvasive cases, there's a lot of heterogeneity in how they would end up because they have to seek medical care, which for a lot of people they're not going to do if they don't have great insurance or if they don't have a hospital nearby. So we don't trust those data as much as others. So basically with any health data, you have to think about how it's collected and how much you're going to trust that data to be representative.
Thank you. Anyone else? Okay, let me ask you a follow-up question on that. When you're trying to come up with policies, strategies to mitigate this type of diseases, what is the best way to proceed since you have at best incomplete information?
Yes, this is always the difficulty in public health, that you have to make decisions based on incomplete data. And unfortunately, there's no one right way to do it. And also remember that when I was talking about why particular organizations might make their choices as far as surveillance, it's limited by funding and by other priorities. They also have to balance other priorities. So usually this is a long process of looking at how good are the data, what do we know we can do, how good are our interventions, and thinking about how can we spend our limited dollars best. So it's not a simple, here's what we do. It often involves a lot of different people coming to the table and saying, here's the data we have here, here's the data we have on this issue, let's make decisions. Just one example that I know a lot of people haven't heard about, but is very useful globally. There is an organization that does the Global Burden of Disease Survey, where they get a whole bunch of infectious disease and other disease experts together, and they try to understand how much does this disease impact the world? How many people are infected? How serious is the infection? How many days of work lost? How many lives lost? All of that put together, and they come up with a ranking of the diseases by how much they impact the world. Deaths, sickness, money spent on treatment, days lost of work, all of that stuff. And they try to come up with these rankings so that organizations can come up and say, okay, TB is at the top. TB and HIV they're at the top of the global burden of disease ranking. So we should spend more of our money on TB and HIV because they have a bigger impact on the world. This is an extremely fraught process because some people, I've done some work in the leprosy world, and they say, well, you undercount the impact of long-term disability compared to death, because leprosy doesn't kill many people, but it causes severe long-term disability. So they say we're too low on the list because of your view of disability versus death. So all of the process, it's very subjective. There's no simple one way. We always say with epidemiology, the answer is always, it depends. And it's a very good rule of thumb. It always depends.
Well, while people get a bit bold and ask a question, I have one more related to the construction of maps that you presented and you try to identify areas of risk, has there been any study correlating changes in climate, broadly speaking, climate change, with the emergence of these diseases?
Yes, many, some with collaborators, and actually Johnny Ullman, who is a current postdoc in my lab, just finished his PhD in September. He is working on this with regards to West Nile virus. So looking at the impacts of climate change, and it's much more complicated, especially with vectors, than you might think, because it's not just hotter temperature better. So it's hotter temperature, faster lifespan, but if it gets too hot, then they can't survive. You know, if the ticks get hot, they're okay, but if they get dry, they're not. So there's a lot of different factors going in. So trying to make those predictions, it's a very complicated thing. But if you're interested in the impacts of climate change on vector-borne disease, there have been some really great new papers by my colleague Sadie Ryan at the University of Florida with their medical geography program. And I highly recommend reading what she's been doing on that issue, looking at malaria and Zika and other similar diseases.
Thank you. This is a very interesting conversation. Okay, let me ask one final time from the audience. Any question that you have in your mind? This is your opportunity to speak with an expert.
And you can always reach out to me later if you have other questions.
Okay, so let me just finish with this. This is something I have been thinking about. While we are very concerned about COVID at this time, um, and you look now globally, what are the areas of concern that you have for diseases that are emerging at a rapid pace, and that we should not take the eye off the ball, because otherwise we're going to be swamped again, as it is happening with COVID? What are those diseases that we should be concerned about and invest some resources and human expertise to try to stop them now before they become a real threat?
That's a very good question. And the answer is there's a lot of them. We are currently very concerned that the rise of COVID is going to impact long-term treatment and control of other infectious diseases, particularly HIV and TB treatment. TB requires a very long treatment schedule. And so if people aren't able to access healthcare because of COVID, they are likely to fall off that, and we'll see more drug-resistant TB. And antibiotic resistance is an issue that I am very worried about. And particularly, we've been chatting among those of us who do antibiotic resistance, we've been chatting about all of that hand sanitizer that we see around campus that says kills kills bacteria. What kind of antibiotic resistance are we building by pushing all of this antibacterial antibiotic hand sanitizer? Got a lot of concerns about the rise of antimicrobial resistance and the fact that we just don't have a lot of new antibiotics in the pipeline. So this is concerning. There are extremely drug-resistant tuberculosis strains that we cannot treat. There is nothing that treats them. And there are other strains, people are moving to phage therapy. So they're finding viruses that attack bacteria because there's no drugs that will work on those bacteria anymore because they're so resistant that you cannot treat them with drugs. But as you might think, finding a virus that can attack your bacteria is a lot more complicated than finding a drug. So I'm very concerned about antimicrobial resistance moving forward. And I think that's an area that there will need to be a lot of work on. Because the last thing we want to do is end up back in the antibiotics phase where a simple scratch could be a life sentence.
Okay, that is very concerning. All right. Well, thank you, Becky, for being with us and for this eye-opening presentation. Just to give you the heads up, next semester we are going to be inviting collaborators from Alan Turing Institute who will have some overlap with the areas that you have described now. And if you could be now our vector into your department to invite them to participate in these discussions, then there will be a panel to try to bootstrap collaborations with them. And there are some funding opportunities as well through the Alan Turing and the University of Birmingham in the UK. So we'll keep you in the loop, and we really look forward to creating bridges with these institutions.
Great, thank you. And it's been nice to talk about my research for a little while.